So good evening, good afternoon, or good morning, depending from where you are joining us tonight. Tonight, the IVPN NeuroPsychiatry, in collaboration with Novartis, is organizing the fourth NeuroSTAT series, which is the last episode of this educational series, which introduced for you some research theories and research lessons, as well as neurological data and real-world evidence about migraine therapies. So I would like first, before introducing our keynote speaker for tonight, Dr. Alessandro Teruzzi, to thank Novartis for sponsoring these educational activities. So our first speaker for tonight, as I mentioned, is Dr. Alessandro Teruzzi. And Dr. Alessandro is currently the head of neurology department at Mediclinic City Hospital and the clinical lead and head of Mediclinic Comprehensive Stroke Center at City Hospital in Dubai, UAE. Dr. Teruzzi graduated from and underwent specialist training in neurology at the University of Medicine and Surgery of Milano Baiocca in Italy, where he also obtained a second-level master degree in cerebrovascular diseases. He was working at the neuroscience department at Manzoni Hospital as a stroke neurologist, where he was the former director of the headache center before moving to Dubai in 2017 as a consultant neurologist. He is also a well-trained neurosonologist, expert in ultrasound Doppler investigation of the carotid and vertebral arteries and transcranial echocolor Doppler. Since 2019, he collaborates with the Mohammed bin Rashid University as an adjunct clinical associate professor. Dr. Teruzzi's primary interests are the diagnosis and treatment of headaches and cerebrovascular disorder. So as the headache healthcare expert, Dr. Alessandro will discuss today the right time to manage migraine, how to manage migraine appropriately, which is the appropriate time on the right patient. Dr. Alessandro, it's always our honor to host you as a speaker and as an expert. Please, you can start the presentation. The floor is yours.
Thank you, Dr. Maya, for the nice introduction, and thank you also to Novartis for inviting me here tonight to discuss with you all about some interesting data in terms of migraine management. So, assalamu alaikum, and good evening to everyone, or good morning, depending on the time zone. As Dr. Maya was saying, I'm Dr. Alessandro, and I will discuss with you some slides about how to manage time in migraine management, or respecting time in migraine management. Next slide, please. So let's think one thing, and when we talk about migraine, we are not talking only about a painful attack that can be disabling for the person for the several hours or maybe a couple of days that is suffering from that attack. Unfortunately, no. Migraine does have what we call an intellectual burden. So there is a continuous, some kind of disability that keeps moving behind the lines in between the attacks. And this can lead to what we know is, for example, impairment in the cognitive domains. Patients with migraine often report that they do feel, even outside of the attacks, a difficulty in concentration, in focusing. They can have a slower processing speed for the information. They can have basic attention deficit. They can have dysfunction of the cognitive functions, verbal, non-verbal memory skills. Not only, this is very common. Every patient with migraine will tell you that not only they do suffer from photophobia or osmophobia during migraine attack, they have to stay in a dark room, they cannot smell any perfume or any food, for example. But even outside of the attacks, they will tell you that, for example, bright lights, they bother them. They need to wear shades. They cannot stay in too bright environment. Even if this is not triggering a migraine, it will be felt as uncomfortable. So overall, there is an empirical impact on the quality of life of our patients, even beside between the attacks. Those patients, they're trying to avoid the triggers to the point that sometimes they have to avoid
Dr. Firozi, I'm sorry to interrupt. There's a problem in the voice quality. I'm not sure if the maybe the headset is not plugged well.
Okay, because we tried before, it was working well, apparently. Can you hear me better now? Any change, any difference?
Maybe if you can.
Is the audio better?
Not yet. Maybe if you can change the headset.
Is better or worse?
Yeah,
Now
you
it's
can
better.
go ahead. Yes, go ahead.
So as we're saying, there is an incremental burden due to migraine that does not translate and does not reflect only during the migraine attacks, but also keep bothering our patients in between the attacks. You can go to the next slide. And as we know, migraine does fluctuate, does change over time. There can be months or years where our patients are suffering from low frequency episodic migraine, and there can be times where the migraine will increase in frequency, becoming high frequency migraine. And we know that there is a risk of conversion to chronic migraine that is 2% per year. And we know that with the increasing number of attacks, there is definitely an increase in disability coming from migraine. And this can happen for natural history and spontaneous fluctuation of the disease. It can also be due to the patient relying on ineffective treatment or using on painkillers, for example. And of course, there can be also adverse psychological or social conditions and other comorbidities like obesity, sleep apnea, anxiety, depression that can have an impact on the frequency of migraine. Next. In terms of management, we know that nowadays we've got several options, and this is a very good news for our patients. We rely on pharmacological interventions and on non-pharmacological interventions. In terms of pharmacological options, as we know, we divide migraine treatment into big chapters: acute phase treatment and prevention. When the frequency of migraine is low, we rely only on acute phase treatment. In the past, we're using hydroergotamine, which we no longer use nowadays anymore, triptans, which we use still, and depans as new molecules that were recently released, and NSAIDs and neuroleptics for the more refractory cases in very specific settings. In terms of prevention, we rely on the oral or the standard of care, that is to say oral antihypertensive medication or antidepressants, anticonvulsants like, for example, candestan, amitriptyline, duloxetine, or topiramate for the convulsants. For chronic migraine, we rely on autoantivenom toxin type A. And in the last few years, we see the anti-CGRP monoclonal antibodies targeting either the receptor of CGRP or the ligand, so the peptide in bloodstream, and some of the GPAs. In terms of non-pharmacological treatment, of course, we can, as we know, rely on support from some allied healthcare professionals like psychologists trained in cognitive behavioral therapy or biofeedback, neurofeedback, which proven to be also effective migraine management and relaxation therapy. We can rely on neuromodulation, so on devices that can help reducing the frequency of migraine, for example, the encephaly device or the non-invasive vagus nerve stimulation, or stimulators for the occipital or trigeminal nerves. Acupuncture also can have some kind of efficacy, and there are, of course, the lifestyle modification, the changes in the behavior, the habits in terms of improving the sleep pattern, changing the diet, improving the level of hydration, avoiding dehydration, trying to manage the triggers or the stressful events that can trigger and can make migraine worse, and so on. Next.
If I may interrupt again, Dr. Alessandro, can you try remove on the headphones and use the laptop mic? Okay. And next now. Go ahead.
Okay, can you tell me how the audio is acceptable?
Yeah, we can hear you. Just try. Go ahead.
Okay. So this in this slide, we can see what happened over time in terms of evolution of the newer migrant molecules. The CGRP as a peptide potentially involved in migraine since the late 80s. And it was documented by the 90s that the CGRP really is the main actor in migraine triggering. So it was really involved in the pathophysiology of migraine. But it took more than another 10 years to be able to finally document what was happening in the brain and how the CGRP was modulating migraine. It was documented that the CGRP is able to act and modulate a periaqueductal gray matter and with connection to the trigeminal-cervical complex. It took another 5 years to be able to demonstrate that we can modulate the CGRP so that not only the levels of CGRP are elevated.
Dr. Ferozi, I'm really sorry. The sound is really cracking. And can you try again from your phone?
Okay, I'll try to log in from my phone. I'll disconnect from the laptop and I'll connect from the phone.
No, keep the laptop connected. Just connect and talk from the phone.
I think we'll give an echo, but we can try.
So we really apologize for and we will wait for Dr. Alessandro to connect again from his phone in order to benefit from his expertise with and his presence with us. So we really apologize from our attendees for this technical error. So which we are trying to solve it. So you
Yes, go ahead, Dr. Alessandro, now.
Okay, do you hear me?
yeah,
Yes, that's
perfectly
perfect.
now. Perfectly now. Yeah.
Okay. So as we're saying, this is the in this slide we can see what happened in terms of the understanding of the role of CGRP in migraine triggering migraine modulation. It was initially discovered as part of the pathophysiology of migraine in the late 80s, but it took more than 10 years to fully understand what was really happening in the brain and how the CGRP was able to interact with the periaqueductal gray matter and then modulating the connection from the PAG with the trigeminal cervical complex. After a few years, it was clearly documented that in the bloodstream of people with migraine, CGRP levels were elevated. In chronic migraine, were constantly elevated, and it was possible to modulate migraine infusing CGRP or blocking CGRP in the blood of humans. This led to the approval finally in 2018 of the first anti-CGRP monoclonal antibody, which was Erenumab, that was launched in 2018 on the market. And since 2018, we received other molecules and we were able to achieve excellent results in terms of migraine prevention for the happiness of our patients, with results that were not comparable to what we're used to see with the oral standard of care. Next slide. And why it's so important to be able to control migraine frequency and severity? Well, because each minute, each hour, each day that the patient is suffering from migraine is time lost in terms of quality of his life, in terms of family life with his family, in terms of also freedom of living a good life. And it also means having an impact in terms of finance, because it means not being able to go to work or spending more money to see doctors or to buy medicines, and also potentially having an impact on the career of those patients. So we are responsible to try to improve the quality of life and to manage their time life better. Next. There are several publications in real-world data on the monoclonal antibodies. As we know, erenumab is the monoclonal antibody with the highest number of manuscripts published in terms of real-world data. Is also the anti-CGRP monoclonal antibody that has been launched in the highest number of countries, and is reimbursed in the highest number of countries as well. Next. So, what time has told us, what have we learned looking at the evidence that has been collected so far in terms of CGRP monoclonal antibody usage so far? Next. Hot topic: when to stop and if we have to stop a treatment with a monoclonal antibody against CGRP. The patient is doing well, and what if we want to stop? What will happen? Is it okay? Should we do it? Should we wait? Next slide. What has been documented in a few very interesting small clinical trials published in Europe is that, and these are real-world data, is that unfortunately, when you stop an anti-CGRP monoclonal antibody, you can expect a high rate of recurrence of migraine. So patients that were, for example, in the German trial, were treated with several different monoclonal antibodies. Majority were on erenumab because it was launched first. Some of them were on tanganezumab and on fremanezumab also. Episodic and chronic migraine, having excellent response regardless of the kind of migraine they were suffering. You can see in the blue column the patients that were treated with anti-CGRP, moving from the blue to the purple column, the improvement in terms of monthly migraine days, but after 1 year of treatment. But in orange, you can see what happens when you stop after 1 year of treatment, any kind of monoclonal antibody. You can see that the number of monthly migraine days increase again. And from the German trial, unfortunately, this was happening in nearly 70% of the patients in the first month up to 3 months. So in the first 3 months, you can expect to see the recurrence of migraine if you stop the monoclonal antibody. Next. And another very interesting question is, okay, we've got these new molecules, but how much more effective are they compared to our standard of care treatment? And are they really effective also in chronic migraine? What about refractory resistant migraine? Can we rely on these monoclonal antibodies? Next slide, please. Well, it was clearly documented and demonstrated in this very interesting study that anti-CGRP monoclonal antibodies are well effective also in patients that are considered, or they were considered, drug resistant, because they are no longer drug resistant when they start responding to a anti-CGRP monoclonal, and also in chronic migraine. In this clinical trial, the real-world data, majority of patients were female, as expected, 42 years of age as median age, also with migraine with aura and not only migraine without aura. and most of them, they were taking erenumab or galcanezumab or fromanezumab, as you can see in the slide on the left-hand side. And these patients were already challenged with oral standard of care that could have been amitriptyline, beta blockers, topiramate, or valproic acid, or flunarizine. And they were also allowed to be on those medication together with the monoclonal before continuing on the monoclonal. And as you can see on the right-hand side, the response before and after 3 months of treatment with the anti-CGRP monoclonal was quite amazing. There was a clear reduction in the monthly headache days. And in the middle, you can see that there was also a reduction in the monthly migraine days. And there was also an improvement in the number of acute medication monthly taken once they were started on a monoclonal anti-CGRP antibody. Next slide, please. And how do the monoclonals compare to the oral medication, this oral standard of care? Do they really offer a significant advantage, considering they are quite expensive medication compared to the conventional anti-migraine molecules that you've been using for many years? Next slide, please. The answer will be absolutely yes, and I will show you now how this was documented and demonstrated. There was this very, very interesting study published with the erenumab medication against topiramate by the German group that randomized patients either to erenumab 70 or 140 milligrams as per the label against topiramate. So patients were taking either erenumab plus placebo topiramate, or they were taking placebo erenumab with active topiramate. And they were randomized 1-to-1, and they were treated for 24 weeks. The first data that was coming out from the study was that the discontinuation rate was very low for those patients that were actively taking erenumab. Only 10% of those patients discontinued erenumab during the clinical trial, while those patients that were taking the active topiramate had discontinuation rate of 38, nearly 40%. So majority of patients with topiramate were not able to continue the medication because of the adverse events, while the majority of the patients that were taking active erenumab were able to continue the trial until the conclusion. Next slide, please. And what about efficacy? So this was in terms of tolerability. What about efficacy? Efficacy of erenumab versus topiramate was also statistically superior. As we can see in this slide, the percentage of patients that were able to achieve 50% response rate in 3 months of treatment was dramatically superior in the erenumab arm compared to the topiramate arm. More than 50% of the patients on erenumab were able to achieve 50% or more response rate in migraine reduction, while only 30%, 31.2% of the patients on the topiramate arm were able to achieve 50% response rate. Patients were 2.76 times, so more than 2.5 times more likely to reduce the monthly migraine days by 50% or more with erenumab compared than with topiramate. Next slide, please. And I want to show you and share with you the results of another clinical trial, the Apollon study, that was just recently presented at the European Academy of Neurology in this July, which is a long-term efficacy and impact of erenumab treatment on quality of life of patients that were participating in this clinical trial called Apollon. Next slide, please. The background for this study is the following. We know that monoclonal antibody erenumab is EMA and FDA approved as an anti-CGRP molecule to treat and prevent episodic and chronic migraine. The German group wanted to document in with the real-world evidence that Erenumab was not only effective but also safe and sustainable with a long-term clinical trial. So they came out with the Apollyon study, which is this assessment for the prolonged safety and tolerability of Erenumab in the treatment of migraine as an open-label trial. These patients were previously participated to the Hermes trial, and they were shifted, if they were in agreement, to the Apollyon long open-label study. Next. So the study design was the following. There was a screening phase, so an enrollment phase of 2 weeks, and then there was this open label long window of 128 weeks of treatment. In this open label treatment window, patients were treated with Erenumab 70 or 140 milligram every 4 weeks subcutaneous injection as per the label, and they were also allowed to take what is called a drug holiday. So if after at least 12 weeks of treatment, they wanted to try to stop Erenumab, they were allowed to without dropping out of the study. And they were, of course, monitored for any kind of recurrence of migraine or the need to start the medication again. And then there was a follow-up phase of additional 4 weeks after the 128 weeks of the open label trial. Patients were assessed using headache diary, HIT6 questionnaire for the impact of the migraines, and a treatment satisfaction questionnaire, which is the TSQM2. Next slide, please. So the demographic of the study was, as per the slide, 701 patients were enrolled in 80 sites over Germany. The patients were coming from the Hermes population. So patients that were treated with either Erenumab or topiramate, as we have just heard a little earlier. And they were exposed to Erenumab for an average of 110 weeks. Most of the patients, 71.6%, were able to take and receive 30 to 33 doses of Erenumab during Apollyon study, meaning that the majority of those patients were able to take Erenumab for a very long period of time. Roughly, we can say that the duration of the exposure to Erenumab, including the drug holiday, was 111 patients per 100, and a little bit smaller number of patients if you exclude the drug holiday. Next slide, please. So if you look at the results from the Apollyon study, we can see that only 29 patients discontinued the study due to adverse events. So out of a total of 155 patients that discontinued the molecule, only 29 they discontinued it for adverse events, which means that 18% only of the patients that had to discontinue needed to discontinue due to adverse events. The other patients, they needed to drop out from the study for different non-medical reasons. And in terms of the most commonly reported adverse events of these 29 only patients, as you can see, majority were reporting nervous system related side effects, including also headaches and migraine. 7 of these patients complained about gastrointestinal disorders, including constipation, and 6 about skin and subcutaneous side effects like injection site reaction, and 7 other kind of side effects, can be dizziness or nausea. And as you can see, the majority of the patients, they were able to continue the medication for the whole duration of the open label trial. Next slide, please. What about efficacy and impact on the quality of life. So on the left-hand side, we can see the results from reviewing the HIT6 scoring of these patients, comparing the baseline on the left to the scores after 6 months and then after 30 months of the trial. And as you can see, the patients improved on an average of at least or more than 6 points compared to the baseline and maintained the same excellent results through the whole duration of the study. Same very good results were documented in terms of satisfaction with the TSQM2 questionnaire that showed an improvement under Erenumab treatment compared to the baseline values in all the domains explored by this questionnaire. So in terms of convenience, as you can see, baseline in blue, month 6 in red, and month 30 in green, there was a reported increase in the convenience as per the patient response. They all reported an increased effectiveness, a global satisfaction, and a reduction in terms of side effects on Erenumab. Next slide, please. So going to the conclusion from the Apollyon trial, we can say that on average, patients were exposed to Erenumab for about 110 consecutive weeks, which is a very, very long period of time. 155 patients discontinued the study in the beginning, but out of these, only 29 discontinued due to adverse events. And adverse events that were reported mainly were related to the nervous system, like migraine or headaches, gastrointestinal, constipation or nausea, or skin-related adverse events. A comparison of the adverse events rate per 100 subjects per year showed a slightly higher value for those patients who suffer from higher number of monthly migraine days at baseline and who already failed on one or more preventive medication. So they had a little bit increased risk, increased rate of adverse events. Male patients overall had a lower rate of adverse events compared to female patients. In terms of HIT6 score, there was an improvement of 6 points within the first 6 months of the study that was maintained through the whole duration of the study. And during the trial itself, treatment satisfaction increased in all observed areas in terms of inconvenience, in terms of effectiveness, in terms of global satisfaction, and also in reduction of side effects. So the results provide additional data from the real-world experience for a very large real-world-based trial by the German group, showing that there was long-term efficacy, tolerability, and safety well documented for patients treated with Erenumab suffering from migraine. Next slide, please. And let's move now to see if all these data were used and were helpful to change also the guidelines. So how time changed also our systematic approach to migraine. Let's see the next slide, please. So the guidelines, they did change. And the good news is that the overall speaking, the amount of data accumulated through all the clinical trials was very good. In this slide, you can see that the risk of bias was considered overall quite low because the majority of the trials, they were able to tick all the possible bias as ruled out. Could have been selection bias, could have been performance bias. Majority of the trial were well conducted from the methodological point of view, ruling out these kind of biases. Next slide, please. So based on this, the European Headache Federation was able to update in 2022 the migraine guidelines, basing the new recommendation on the level of evidence coming from all the clinical trials collected so far. And as you can see, the strength of the recommendation was strong in terms of using anti-CGRP monoclonal antibody for episodic migraine prevention. And if you look on the left-hand side, you can see that the quality of the evidence was also very high for all the monoclonal antibodies. Same conclusions were given for the chronic migraine prevention with the monoclonal antibodies against the CGRP. Level of evidence, so strength of recommendation was strong, and the level of quality of the evidence of the data was also considered very satisfactory for all the monoclonal antibodies for the prevention of chronic migraine. Next slide, please. So this is the part of the guidelines where the statement was compare anti-CGRP versus other migraine preventive treatment, basically looking at the data from the Hermes trial. Anti-CGRP monoclonal antibody erenumab was able to demonstrate superiority against topiramate in terms of efficacy, tolerability, and sustainability. Next slide, please. And again, the strength of the recommendation was considered high, so the strength of recommendation was considered strong. The quality of the evidence, in this case, from the AHF, so European Headache Federation point of view, was considered low, not because the quality of the data is not good, but only because there was only one clinical trial published at that time with a head-to-head comparison of an anti-CGRP monoclonal compared with the oral standard of care, for example, topiramate in this case, for migraine prevention. So based on the evidence of the paper, the data were very good and very strong, but the quality overall of the evidence was considered low because it was based on only one single publication, meaning that we need more publication on this very delicate topic. Next slide, please. So in 2022, the European Headache Federation published the updated guidelines for migraine management. And this was a milestone because they were able to agree and to state that individuals with migraine who require preventive treatment for migraine, monoclonal antibodies targeting the CGRP pathway can be included as a first-line treatment option. So moving from the previous statement, or for example, American guidelines, where it was necessary to demonstrate the failure of at least 2 or more preventive medication, the AHF now is confirming that you can also consider using the anti-CGRP monoclonals as a first-line treatment for selected patients. Next slide, please. So is it time to appraise or to reappraise our approach to migraine prophylaxis? And again, the answer will be yes. And we'll show you why now. Next slide, please. This is the last trial that I wanted to share with you, but it's a very, very relevant trial with amazing data, I would say, because the first global pragmatic phase 4 randomized active control clinical trial that compare the efficacy and safety long-term benefit of erenumab, so an anti-CGRP monoclonal, 70 or 140 milligrams against oral standard of care preventive molecules, including amitriptyline, topiramate, flunarizine, and so on, in episodic migraine prevention. So patients were randomized and compared under oral standard of care versus erenumab. Can you see the next slide? And the primary composite endpoint was 50% responders who were able to complete 12 months of treatment on their initially assigned medication. So how many patients that were initially assigned to erenumab were able to achieve 50% response rate after 12 months of treatment and to stay on the treatment? As you can see on the left-hand side, more than 56% of the patients were able to complete 12 months of treatment with a 50% response rate. How many of the patients that were initially assigned to one of the oral standard of care were able, after 12 months, to remain and to show 50% response rate, only 16.8%. So patients on erinumab were nearly 6.5 times more likely to stay on the assigned treatment. So erinumab through the 12 months of the trial, achieving 50% reduction in monthly migraine days at month 12 compared to any oral standard of care. Next slide, please. And if you look at the overall number of patients that were able to complete the 12 months of treatment, you have seen in this previous slide, nearly 90% were able to stay on erinumab, while less than 40% were able to stay in the oral standard of care. And what about the secondary endpoint? What was the change from the baseline in the cumulative average monthly migraine days comparing patient under erinumab treatment versus the oral standard of care? And it is clearly visible that patients under erinumab treatment were able to achieve a dramatic and superior reduction from the baseline in terms of cumulative average monthly migraine days compared to standard of care oral preventives from the very beginning of the trial until the completion after 52 weeks of treatment. Treatment with erinumab significantly reduced the average monthly migraine days through the study compared with the oral standard of care. Next. The other secondary endpoint was the response rate measured with this questionnaire that is a self-reported questionnaire in terms of satisfaction. And you can see that 76% of the patients reported a perceived dramatic improvement in terms of monthly migraine days compared to the 18% only on the oral standard of care. And the number of patients that discontinued the treatment due to the adverse events was only 2.9% in the erinumab group compared to 23.3% on the oral standard of care. So there was a significantly higher number of drop-offs on the oral standard of care compared to the patients treated with erinumab. Patients on erinumab were 13.7 times more likely to achieve a relevant clinical improvement with erinumab compared to those patients that were instead taking oral standard of care at month 12 of the clinical trial. Next. So, going to the conclusion, safety information for erinumab based on all the data that you have seen so far, more than 2,500 patients have been treated with erinumab in registration studies. And of these, more than 1,300 were exposed for more than 1 month to the molecule, and more than 200 patients were exposed for more than 5 consecutive years. The overall safety profile of erinumab remained consistent for the 5 years of treatment of the long-term open-label trials, showing that the safety and efficacy were absolutely confirmed. The number of reported adverse events for erinumab were mainly injection site reactions, 5% with the 70 and apparently a little bit less, 4.5 for the 140 milligrams. Constipation was reported in 1.3% with the 70 milligrams and 3.2% of patients with the 140 milligrams. Muscle spasm in less than 0.1% and 2% with a higher dose, and pruritus in 0.7% with a lower dose and 1.8% with a higher dose. Most of the reactions were mild or moderate in severity, and less than 2% of the patients in the trials discontinued due to adverse events. Next. Just to say thank you for the attention and sorry for the inconvenience of the connection. It was working well in the beginning and then we had this technical problem. I hope that the lecture was still clear enough, and now we'll leave the stage open for the question and answer session.
Thank you so much Dr. Alessandro, for a very enriching presentation, and from really presenting this innovative data. I think very rarely we see head-to-head clinical trials comparing different therapeutic approach in any disease, and here you presented wonderful data about a head-to-head comparison between a traditional therapy for migraine and one of the therapy that is very commonly used traditionally for the treatment of migraine, which is topiramate and erenumab. So it was really very interesting. And here come my question to you. So if you have a patient newly diagnosed with the migraine, do you start him on one of the traditional therapies like topiramate, for example, or do you start erenumab as or any other anti-CGRP as first-line therapy?
Thank you for the question, which is probably the most asked information. I would say that it depends on the characteristic of the patient. I would say that nowadays the tendency, and this is my personal opinion as a headache specialist, is to try to rely, if it is possible, on the monoclonal antibody, anti-CGRP, more frequently and more most of the times compared to the standard of care for a few simple reasons. We have seen that the data are absolutely strong and of good quality in terms of superiority of efficacy and of tolerability. These molecules, they offer a dramatic advantage in terms of fast onset. Patients start improving in the very first month of treatment, up to the very first week, and sometimes the very first few days of treatment with the anti-CGRP monoclonals. While with the oral standard of care, we always have to wait 2 or 3 months before seeing a very consistent improvement. Safety and tolerability are so much better with the anti-CGRP compared to the oral standard of care that makes them the ideal choice in a cost-effective setting. Of course, for those patients with a very low frequency migraine, probably I will not start this kind of molecules. I will consider other treatment options first. But if the patient is having high frequency migraine or chronic migraine, I will not wait before starting a highly efficacious treatment, as we like to call them, mirroring what is happening for MS for migraine with the anti-CGRP.
Yeah, and I think the convenience of the dosing as well is one of the advantage of erenumab. So taking 1 injection per month instead of taking 1 or 2 tablets or 3 tablets daily, probably, and this will increase adherence to therapy. But Dr. Teruzzi, here come the question of the cost and insurance. So do insurance company cover erenumab as first-line therapy?
So yes, it's not always easy to get the approval as a first-line treatment, but now we have the backup of the European Headache Federation guidelines, which is an international consensus for one of the most important and, of course, relevant scientific institution that tell us that we can also use anti-CGRP monoclonals as a first line of treatment. So we can ask for insurance approval, for example, for erenumab as a first line option if we can demonstrate that the patient has high frequency of attacks, high disability. It's always important to, for example, attach to the medical report MIDAS score, HIT6 score, so we can clearly document the level of disability that is coming from the migraine, the level of discomfort the patient is going through, the cost due to emergency, for example, department visits, anti-inflammatory or symptomatic medications. If we provide these informations, we can also achieve approval from insurance with the first line treatment for the anti-CGRP, yes.
I know, doctor, that you have discussed the safety profile of erenumab, which is favorable. However, one of the attendees is asking about your real-world experience and what are the side effects your patients are experiencing, your erenumab-treated patients are experiencing.
Sure. So I must say that, for example, constipation, which is a highly discussed topic, especially for erenumab as an anti-CGRP receptor blocker, in clinical practice, we do see it less than expected. I had only one patient so far that need to discontinue erenumab because of constipation, for example, and the majority of the reported side effects are the local site injection reactions. So a few days or some redness and itchiness in the injection site. Most of the patients, they will report only this. A few patients reported some kind of discharge from the nose and like a cold or flu increased episodes during the winter time. Like as we know from the clinical trials, some nasopharyngitis were reported, but the majority of the patients, I must say, regardless of which monoclonal you're using, they will do well not reporting side effects nearly at all.
But just to clarify one thing, and correct me if I'm wrong, so usually if a patient develops constipation on erenumab, we don't discontinue immediately the medication, but rather we try with laxatives and before, right?
Yes, you also have to consider one thing, that majority of the patients that report constipation usually are, most of them are taking other molecules that maybe you are not aware because we forgot to ask, that are giving the constipation, and erenumab is just adding on top of that. So if you can manage their constipation in advance with fiber in the diet, good hydration, physical activity, or eventually removing other molecules, let's think about amitriptyline, that can be giving constipation, then erenumab will no longer be playing that kind of trick against us. So yes, we have to manage in a holistic way this possible side effect, because it's much less than what we could expect and what could fear.
Doctor, another question. You have also tackled the success rate and the efficacy of erenumab, but what about the failure rate? So what is the frequency of patient who fails erenumab or anti-CGRPs?
So from the data from considering talking about all the CGRP, we can say that majority of the patients, so more than 60 to 70% of the patients are able to achieve easily 50% response rate. Half of them, they can achieve 75% response rate, and nearly 30% can also achieve 100% response rate. This, of course, does not mean that every single patient will be a responder to an anti-CGRP, but we can expect a high rate of responders if we start them on the anti-CGRP monoclonal antibody. Let me just add one thing, that is if the patient is not responding to one anti-CGRP, I would advise to try and consider what we call a lateral switch. So to move from one anti-CGRP to a different one, because sometimes there can be differences in the response rate in a subjective way if you are modulating the ligand or the receptor. So it's worth always trying at least to move from one to another.
The final question, Doctor. Dr. Amit is asking, what about the use of valproic acid in migraine? So do valproic acid have a role in the treatment of migraine?
So this is a very good question, because in terms of clinical data, we don't have big data. But in terms of clinical practice, I think that all of us as headache specialists, we use valproate for refractory cases in the emergency department, for detoxification before giving Botox, with very good results. So in terms of efficacy, as a clinical practice, yes, it does work. The problem is that tolerability and safety. That is why valproic acid is no longer used as much as an migraine preventive treatment because of the high rates of side effects and tolerability problems, tremor, hair loss, weight gaining, which is a big problem, especially in women, and of course the hormonal problems, the risk for the pregnancy if a lady becomes pregnant with treatment with valproate. For all these reasons, we are honestly no longer using it in migraine prevention. And if you can start an anti-CGRP moving from topiramate or amitriptyline, you will see so much better results that you will no longer think about valproate anymore.
And what about combining anti-CGRP monoclonal antibody with Botox treatment? If there is a rational combination?
Yes, absolutely. So this probably will not happen frequently in terms of clinical practice, but if you have a patient that have only those dramatic, very challenging cases, chronic migraine, refractory to everything, that you put on a monoclonal anti-CGRP, they do improve, but they do not improve so much as you were expecting. You can try to combine also Botox because Botox will modulate the CGRP pathway in a different way. They work on the delta fiber and the C fiber, the two molecules, so they can really combine their efforts, improving the response. There are very interesting papers that have been published since 2022 showing the improved response if you combine Botox with the anti-CGRP, of course, only in selected patients with chronic refractory cases.
Those were the questions. Thank you, Dr. Alessandro, for sharing this information, for updating us on all the new data about the comparative efficacy of those medication, and for answering all our questions. And thank you for accepting our invitation and being with us tonight. So
thank you so much. Good night.
Good night. And we will move to our next speaker, Dr. Hani Dimasi. So Dr. Hani Dimasi is currently an associate professor of biostatistics at Lebanese American University since 2012, with a PhD in biostatistics and an MPH in epidemiology. He provides his students with enough theory to understand how statistics work, but he also makes them understand the application and utility of statistics in the health field, namely in advancing knowledge. Dr. Dimasi taught in multiple disciplines: nursing, pharmacy, biology, medicine, and at different levels and in different setups. He also provided researchers in a variety of health-related fields with statistical as well as methodological and research design support. In the research year, Dr. Dimasi has contributed in a number of publications related to access to health service among refugees, nutrition, oral health, and pharmacy work environment. Tonight, Dr. Dimasi will explain to us how head-to-head clinical trial works and how we do randomization, and what is the importance of randomization in minimizing bias and in comparing different therapies. So Dr. Dimasi, we are really lucky to have hosted you through all these series, and thank you for accepting again our invitation, and the floor is yours.
Thank you, Maya. Thank you for a very nice introduction. And again, thank you for inviting me. I'm so happy to be here talking to many healthcare providers from different fields through this setup. It's really a pleasure. Can you hear me well?
Yes, we are hearing you perfectly.
Okay, so I'm going to share my screen. And this is my presentation. I hope you can see it well.
We are seeing it.
Okay. So the title of my presentation focuses mainly on randomization in head-to-head trials, basically, and trying to elucidate what is the big deal about randomization. So if you start with the rationale of randomization in terms of why we do randomization, maybe it's helpful if we take a step backward and try to understand why are we trying to achieve when we're doing a head-to-head trial. The idea usually of trials is because you want to compare treatments, and I have treatments between quotations because these could be treatments, could be procedures, could be anything that you're trying to do with your patients, and you want to know which one is, again, better. So how do we know if one is better than the other? The obvious answer is that you're going to start with two groups of patients, and you're going to give one patient the first treatment, the other group, you're going to give them another treatment, and then you're going to compare what's going to happen to them, hoping that one is going to fare better than the other. And you really want to look at only the effect of the treatment and nothing else. You really want to make sure that what you're looking at is caused or due to treatment A versus treatment B. So when I was thinking about this, I thought about something that we see it elsewhere, and it kind of makes sense, which is when we have a race. You have multiple racers that are going to take the race, and you want to know who's going to win. And something that we're all familiar with is that at the beginning of the race, the racers line up before they start. So why do we line them up? And what are we trying to do when we're lining up? Well, you're trying to give them the same starting point, and none of the race has an advantage or a disadvantage. Everybody starts at the same place. And basically, that's the same idea when we're trying to do a head-to-head trial. We want to make sure that these treatments, they all start at the same level. They start at the same place. So how do we line up treatments? How do we line up things like that? How do we make sure that they start right at the same place, knowing that participants, they come with different factors? It could be predisposing factors, could be age, could be gender, things related to their socioeconomic status, could be their genetic predisposition, their life habits, they smoke or not, they exercise or not, it could be their prognosis, it could be how bad their health condition with. And all of these would, in theory, they could impact the outcome. They could impact how well a patient is going to perform with a certain medication. Therefore, if you do not line them up, if you do not take care of the differences that start at the beginning, then there's always a leeway or a room that someone might say, well, the difference that you're observing is not because drug A is better than drug B, is because they started up differently. So some of the effect that you're seeing could be attributed in part or in total to the fact that these participants were not the same when they started, not the same in terms of who went into drug A and who went into drug B. The problem of not having the same characteristics, baseline characteristics between group A and group B, this is what we call selection bias. If you don't line it up at the beginning, then you're going to have a problem, which, again, going back to the same idea, if I have a race and there is a winner, then how do I know that the winner won because he or she is the fastest participant, and not because they received a head start, not because they have better shoes, not because they were running on a lane that was better packed, etc. So that's where you want to make sure that you line up, you give them the same equipment, you pack the line exactly the same. Well, that idea of giving equal opportunity to the treatments also apply in research. So what we do to address that problem, this is randomization. So randomization, I'm calling in here, it assures the fair lineup of the treatment right at the beginning of the race or of the trial. So when you line them up, you're making sure that everybody start at the same place. Now, theoretically, one can say, well, how about instead of randomizing, as I recruit my participants, I make sure I split them equally. I make sure that I have 50% taking drug A, 50% drug B. I make sure that I have equal distribution of gender in the two groups. I have equal distribution of the age, smoker, etc. And I'm hoping that as you're thinking of all the baseline characteristics that may impact the outcome of your treatment effect, you start to appreciate how difficult that would be if you want to do it by your proper selection of who goes in A and who goes in B. And many times this becomes not feasible, not practical, and sometimes it's not even possible because you may need to run some tests that are too expensive for you to run to make sure that they have similar characteristics. You may not know about certain characteristics that you should have lined up, but you were not aware, and that may cause a problem. Therefore, in research, that is not done. That's not how we do things. What we do is we randomize. So randomization is the random allocation of participants in either taking drug A or drug B. So I'm going back to A and B because the title says head-to-head. But knowing that you may have more than 2 treatments, you may have 4 treatments, etc. But the concept still applies. So what you're trying to do is you're trying to allocate patients in receiving drug A or drug B. And the way you're going to give them drug A or drug B, you're going to do it by pure chance based on a probability. And if you do that correctly, you're going to end up with equal groups just by doing it using a fair allocation. By the end, you finished your recruitment, you're going to have equivalent groups. You're going to have same number of gender here and here, same age distribution here and here, etc. So that's what randomization does. It takes care of all the baseline characteristics that may impact the outcome. And keyword that you hear is that it's going to take about baseline characteristics that you know about, but also about baseline characteristics that you may not know about. And that's the beauty of randomization. In fact, randomization is considered one of the 3 pillars of full experimental design. When we talk about full experimental, because we have something called quasi-experimental, or even we have something called pre-experimental. But if you want your design to be a full experimental, which most RCT are, then you have to have the 3 pillars. You have to have a manipulation, you have to have treatments that you're allocating and they're not doing them by themselves. Otherwise, if you lose manipulation, it's no longer an experimental study, it becomes an observational study. So you have to have that. You also need a control group. So your control group could be a placebo or could be another treatment that you want to compare your new treatment to. You have to have that so that you have a comparison to compare to. And that's where your 3rd pillar comes in, which is randomization. Notice blinding is not part of the 3 pillars. Things that we usually do that are important in research are not part of the 3 pillars. Fall in the 3 pillars, and I want to stress out that randomization is one of the pillars. Now, mind you, not to confuse randomization with random selection. So randomization is you're recruiting participants. That could be in different ways. But once you've recruited a participant, the decision of whether this participant is going to receive drug A or they're going to receive drug B, that process is going to be using a random process, a chance process that is fair. Okay? So how is it done? How do we randomize? Well, if we simplify things in a very simple setup, in the most simple setup, what you do if you have all your participants, you already recruited them, they're already there, then you can split them into receiving drug A or drug B using any kind of chance distribution. It could be a computer-generated software as simple as an Excel sheet, and I'll show you how I did that. It could be a ballot, any kind of process that allows you to put them into either of the arm. So I did it using an Excel sheet where I have all my participants ready, and then I generate a random allocator, and that random allocator is going to tell me should a participant take drug A or drug B. So here I'm showing you an illustration, very simple illustration. If you look at the first columns, A and B, this is where I have only 10 participants, that's it. And I'm looking at age as being one of the factors that I'm worried it may impact the outcome. So I want to make sure that the age distribution between A and B is the same. So what I do, and that takes you to the second set of columns, is that I have added this random allocated variable, and it's created in Excel. It's very simple. You just type it in. It's gonna create, it's either a 0 and 1 randomly for each of these 10. And you're going to get 5 zeros and 5 1 randomly. And if you look at the zeros and the 1, they're not sequential. It's not 1 0 1 0 1 0. No, they happen in a random fashion. And then what you're going to do is you're going to go to the last part where you're going to put all the zeros together and all the ones together. And you say all the zeros get treatment A and all the ones get treatment B. So you can see that the first recruiter, ID number A and the number 1 is getting treatment A. The second one is actually in the second group, that's a B. 3, 5, 6, 7, all of them are taking drug A versus 2, 4, 8, 9, 10, they're taking drug B. Now, obviously, this is a very small sample, so the randomization would work much better if you have a larger sample size. But just to illustrate how it actually works, if you look at the average age of all the 10 together, the average age is 27.8. By just randomly putting them in A and B, I end up with an age of 28.8 in group 1 and 26.8 in group 2, which is not that different for such a small sample size. If I had larger sample size, if I'm doing this for 1,000 participants, I can assure you that the difference in age is going to be much, much, much smaller. So it actually works. This is how it's done in a very simple manner. So, but the reality of thing is when you're doing an RCT, you don't have the luxury to wait till all your participants have been recruited, and then you start splitting it out like I did now. Because that means, when you're recruiting thousands of participants, it may take a whole year, for example, to get them all. You cannot tell participants, well, we're recruiting you for the study, wait till the last one is recruited, and then we're going to decide on which treatment you're going to take. Obviously, you're going to lose them. So what is done is, in fact, the randomization process is going to start as you're recruiting your participants. And this is very easily done. So what you're going to do is you're going to have a participant order of recruitment prepared. So from the first to the last, you're going to generate your random allocation, whether they receive A and B. And then you're going to prepare a list of medications for these people with a serial number that matches the recruiting order. And that serial number will also indicate whether receiving drug A and B, but that information is going to be blinded to those who are actually running the process of recruitment. So I'm going to show you in this example how this is done. In the first set of Excel sheet, you can see that I have a theoretical example of recruiting 20 participants. And this is the order of recruitment. So no matter who's recruited the first, the second, the third, all the way up to 20. And that take a couple of months till I've recruited all of them. I prepared a randomly allocated treatment list of who's taking A and who's taking B. This is done before I actually recruit my participants. I talk to my pharmacist. I tell them, this is the order that we're going to go through. Please prepare boxes for the treatment that look exactly the same. There's no way to tell which is A, which is B. But using your serial number, you're going to make sure that box number 80,001, for example, gets 80,002 gets B. And you're going to communicate the list without whether it's a direct A or B to your recruiter, which is going to be the second set of the Excel sheet. So your recruiter, all they know that if I recruited the first participant, that first participant gets the box, the treatment box labeled 80,001, not knowing if it's drug A or drug B. But that actually happens to be drug A because my pharmacist prepared that already. And as I'm recruiting, so I'm a nurse, I work in a clinic, there's a patient, we recruited that patient. That patient happened to be the 7th recruiter. I put my box labeled 80,007 and I give them the treatment, not knowing if it's A and B. And they themselves, they don't know if they're receiving drug A or B. That solves the problem of randomizing without waiting till the end of the recruitment. So this is called simple randomization, where you've randomized everybody in one shot. Simple randomization, where you randomize your entire sample in one shot, good, it works, but it only guarantees that you're going to have equal distribution when you finish your randomization. When you finish your recruitment. So only when you finished recruiting the 5,000 participant, the 3,000 participant, where you will see that they are exactly equally distributed. Okay, so I'm going to show you an example. Before I show you an example, so what I wanted to say is that if for some reason I'm recruiting these 3,000 participants, and I know that by the time I finish recruiting all these 3,000, I will have 1,000 here, 500 here, 1,500 here, and they will be similar at the end because that's what randomization does. But if for some reason you need to stop your study, or you have a request for a preliminary analysis or an early comparison just to see how it's going. So you're not done with the 3,000. Maybe you've recruited only 800 and you want to compare these 800. If you're doing simple randomization like we talked about, they might not be equal yet. Because as I said, it's only towards the end that you will have equal distribution. So I'm going to show you an example. Again, it's a very simple example. I'm recruiting 100 participants in this one. So you have your recruitment order from 1 to 100. The second column is showing the random allocation of either receiving drug A or drug B. And it's going to be 50. The second two variables are variables at baseline that are of interest. And I would hope that by the end, they will be the same between the two. So once I finished my entire recruitment, I have 80% white in my entire sample, and I have an average age of 49. If I come at the end of the recruitment and I start comparing the two groups, I have 50 taking drug A, 50 taking drug B, perfect. If I look at the percentage of white in drug A, it's 78%. In drug B, it's 82%. So it's not exactly the same, again, because the sample size is small, but still they're pretty close. Remember, this is only by chance. And if I look at the age distribution, I have 50 years age in drug A, 48 years in drug B. Again, for such a sample size, this is pretty close. So it means that when I'm done recruiting, it's 100, kind of a very similar distribution in the two groups. However, if for some, and this actually is a simulation that I did, these are real numbers that I actually prepared for this presentation. If for some reason, by the time you recruited your 45th participant, FDA requires a preliminary analysis, or you have reasons to run a quick safety analysis or something like this, and you want to compare these two groups, so you're not done with the 100. Well, in my simulation, if I stop at 45 and I start comparing the two arms, first, I don't have equal distribution of the drug A and B. I have 24 in drug A and I have 21 in drug B. Second, if you look at the race distribution, I have 87.5% white in drug A and 76.2 in drug B, a difference of more than 10%, which is quite large for a sample size like this. And if I look at the age, I will see that I have an average age of 55 in drug A and 50 in drug B. Again, a difference of 5 years, which again, for a sample size like that, this is quite large. So I ended up with an unbalanced design if I stop early for one of the reasons I've listed. So how do we fix this problem? It was suggested one of the solution is that to do something called restricted randomization, or another term for it is block randomization. And basically what does is that instead of randomizing the entire 100 participants in one shot, What you're going to do is you're going to split them into what we call blocks. And the blocks have to be even numbers so that they can be split of equally. So here you have an example. My first block is made of 4 participants. And these 4 participants are going to be randomly allocated between A and B. Then I move into my second block. My second block in this instance is made of 8 participants. And these 8 participants are going to be randomly allocated between A and B. And then you move. So the size of your block in the example I'm giving you, and the one that I'm simulating here, varies between 4, 6, and 8. And the order of whether it's 4 or 6 or 8 is also done randomly. Mind you that some randomized clinical trial, they prefer to have a fixed size. So if you're going with 4, you do 4, 4, 4, 4, 4 till you finish your sample size. If you're going with 6, you do 6, 6, 6, 6 till you finish your sample size. So what is the advantage of doing that? So instead of randomizing everybody, I randomize blocks. So let me show you what happened. I'm still using the exact same example. I have 100 participants. These are the same 100 participants, the same age distribution, the same white race distribution. And as I told you previously, at the end of the recruitment, they're quite similar. Now, in this instance, because I didn't randomize all of them in one shot, I went through the blocks. So every block got to be randomized separately. If I were to again at 45, now I have 23 in block A and 22 in block B. So the difference between how many I have in every group becomes very small. Also, if you look at the race distribution, I have 82%, 82.6% in drug A versus 77.3% in drug B. The difference we saw a minute ago has dropped down quite a bit. Also, if you look at the age distribution, now I have 53 in drug A and 52 in drug B. And the difference that we saw a minute ago of 5 years has been reduced to only 1 year. So the idea of blocking is that you're going to assure some sort of balanced randomization, a balanced grouping between the two, even if for some reason you have to stop early in your process. Another issue with randomization, with simple randomization, is that this happens usually when you have multiple centers that are recruiting your participants, and you want to make sure that you have equal representation from every sample, meaning you want to have drug A and drug B equally represented in center 1, center 2, center 3, etc. Or if there is specific characteristics of the patient that is so important that you want to make sure that they are equal, what you do is before you randomize, you stratify your participants according to that important variable, and then you randomize. So this is called stratified randomization. So basically what stratified randomization says, before you randomize, you stratify according to that specific characteristics. So for example, if I want to stratify by the center that are recruiting, then every center will have their own randomization. So patients are first stratified according to which center they come to, and then there is a randomization in that center, and then randomization in another center. The example that you have in the infographics I have in front of you, they stratified first by gender, and then they stratified by age, then they randomized. So a patient, they want to recruit 1,000 patients. As a patient is recruited, it's either a man or a woman. So that is determined. Then their age is determined. Then they are randomized. So what that is going to do is that at the end, you're going to make sure that you have equal representation of the gender and equal representation of age. But remember, this is only done when you have a very strong reason why you want to stratify first. And as I said, this is most of the time it's done if you have multiple centers within, maybe, for example, the US, and they're recruiting, so you want everybody to randomize within their own centers. The last issue with randomization that the researcher may face is that when you're recruiting a group of patients that have very strong ties, so they could be, for example, family members, and you want to recruit all of them. So it becomes very hard becomes very hard to randomize a man and his wife to different treatment because they live in the same house, especially if it's a procedure. They may share the medication or what we call contamination. And this comes for a little bit of history from the AIDS study. When the AIDS participants, they had such a strong ties between themselves because they knew each other and they have a support group. So every time they were recruited in a clinical trial, when they end up doing is they ended up sharing their medication, knowing that they may or may not receive the treatment versus placebo. So, and therefore, in their support group, they would bring their medication and they would share it, like put all medication together and redistribute. And that kind of like kills the effect of comparing drug A and B, because you no longer have drug A and B, you have a mixture of A and B versus a mixture of A and B. So in that situation, you do not randomize individuals, you randomize clusters. So that also may happen if you have a multi-center study, but some of the centers, that are part of the recruitment are, very far away. So maybe the study is set in the US, but they have centers in, let's say, Brazil, centers in Djibouti, centers in Lebanon, and they don't have a lot of control of how the randomization is working in every one of these centers. So they may decide that instead of randomizing individuals, they're going to randomize centers. So randomly, a center is selected to receive only treatment, and randomly, a center is going to receive only placebo. And obviously, the PI at that center, or I'm sorry, the provider of that center would not know if they're receiving treatment while placebo, and the recruiting participants would not know. So this is a cluster randomization, and so I talked about why it's done. A last approach for randomization is called adaptive randomization, that is used when, as you're recruiting, you may change the probability. So you don't prepare a list as I did in my example. Rather, as you're recruiting, the chance of either going to drug A or drug B shifts a little bit based on either a predefined knowledge. So for example, you're going to have a lot of dropouts from those that are receiving drug A because of maybe side effects. So you already know that you're going to have a lot of dropouts in drug A versus drug B. So you shift the probability of going to drug A to increase it. Or another example, which we faced in one of our clinical trials, we were recruiting and we were randomizing, block randomization, etc. But as we did a preliminary analysis, we noticed that for those taking the placebo, we have a big chunk that are dropping out of the study. And we wanted to make sure that when we end our study, we have equal numbers. So we shifted the probability of whether receiving treatment A versus the placebo as we were selecting. So adaptive randomization is also another approach. Here's a few examples of randomization in the literature. Here you have an example where patients were randomized in a ratio of 2:1. So right from the beginning, they decided they're not going to have equal numbers into the treatment versus the placebo. They wanted double the numbers of treatment versus the placebo. And if you read what they have, is patients were randomly assigned to treatment that was stratified according to the study site. So as I told you, before randomization, they were stratified to which site they were coming to, and there was a block of 3 that was used part of the randomization. And this is because they were recruiting them 2:1. That's why they chose a block of 3. Another example of randomization, which used a cluster randomization, is this study, where here they were worried that the impact was the education of the general practitioner, and every general practitioner was supposed to get 15 patients. And they thought it was going to be very hard to control contamination in this setup. So instead of randomizing patients, they clustered the patient according to their general practitioner, and the general practitioner themselves were randomized, making an example of cluster randomization in the study. Also, I would like to mention that the consort statement, which stands for Consolidated Standards of Reporting Trial, which came out maybe in the late 90s and has become one of the standard statements that people either evaluating clinical trials or doing clinical trials need to fill and to submit. They have a list of statements. They have included part of their statement, a few items about randomization, including masalan, what method was used for randomization. If you're writing a good article, you have to specify what is the method of randomization. Also, for example, was the randomization concealed, etc. So I'm just pointing out that it has become such an important issue that in the consort statement, there is a whole thing about it. There is something that looks like randomization that is not randomization, and we call this pseudo-randomization, where patients go into either arm based on something like their date of birth, if it's even or odd, or the record number, or the day of recruitment, if it's Monday, Wednesday, or Friday versus Thursday, Tuesday, Thursday, Saturday, or the odd-even recruitment, 1 takes A, 2 takes B. These methods are not actually randomization. These are considered pseudo-randomization and not appropriate to use. There is a technique that has been adopted to mimic randomization in observational study. Obviously, observational studies, they lack the manipulation. So in principle, they lack the capacity of randomizing. But I thought it would be interesting to note that even in observational studies, they try to mimic randomization. And this is called the propensity score matching. What they try to do is if they have an observational study that has 2 sets of arms, so those that by themselves are taking drug A and those by themselves are taking drug B, and they want to equalize them. Well, there is a technique called the propensity score where they generate a propensity score for all the participants based on if they went to drug A or drug B, if they selected themselves drug A or drug B, using the logistic regression. Every individual would receive a probability, which is a propensity score, and then you match them. So yeah, so I find a participant in drug A, their propensity score, let's say 0.25. I look for someone that is taking drug B with the same score, and I match them. By doing so, you're actually creating a lineup in observational study. Mind you, not everybody is going to be lined up. Some of them are not going to be lined up, and then you're going to have to exclude them from your analysis. So that's what I was just talking about, the propensity score. I find this infographic to be, interesting because it shows the idea. It's like, in the upper circle, that says everybody the way they came. And then you start looking at them and you start lining up them. And you may line up a number between blue and gray. You may have blues that you cannot line up and gray that you cannot line up, but your analysis is going to focus on those that you were able to line up. And then these set that are actually similar and they have been equalized. This is an example of the literature where they use this method, propensity score. You can look that before they did the matching, there was a lot of statistical difference at the beginning of the study, but after they used the propensity score, many of the differences were taken care of. Also note that the sample size changed quite a bit from about 136,000 down to 75. As I said, you were not going to be able to line up everybody in observational study. So in conclusion, randomization is a research design technique that aims at eliminating bias, making sure that everybody is the same at the beginning. Randomization has become the standard method of allocating patient to treatment and experimental studies. There are different methods of randomization, as we discussed, with advantages and disadvantages to each one of them. And please bear in mind that randomization is not fix-all solution. Still, good research methodology need to be addressed, such as blinding, appropriate statistical tools, a good sample size, a good follow-up, eliminating provider bias, etc. So that's it for my presentation. I'd like to finish by thanking Maya again. Thank you so much, Maya, for the invitation. IVPN, NeuroPsychiatry, and Novartis for this opportunity. Thank you, everybody.
Thank you, Dr. Dimasi, for an excellent presentation as usual. So please allow me to take some questions. So the first question, one of the attendees is asking, can we do randomization using SPSS and not Excel? Is it possible?
I'm sure there is a way that you can do it in SPSS. But again, Remember, usually we use SPSS once we've collected the data, we entered the data, and we want to start analyzing the data. Remember, randomization, we tried to do it before you actually started collecting the data. I mean, whatever software you feel comfortable with using, go ahead and use it. There's a lot of literature out there. Use whatever you're comfortable with.
And since you mentioned that we do randomization when planning the study, actually, so before even recruiting the patient and collecting the data, so what if we do the randomization plan for a reason or another, the study was stopped or terminated earlier, and we couldn't reach or we could not recruit the planned sample size? What happened with this randomization plan?
So in any trial, you will have a scientific committee responsible for looking at how the study is going on. And depending on the setup, why this is happening, they will have a contingency plan of what to do. As I said, the good news is if you're doing a good randomization using block, even if you were forced to stop, which it happened, and in one of the examples that I share with my students is that they had to stop because they divulged some of the results. The pharmaceutical company they were working with divulged some of the results, so they had to stop it before the sample size. But because they were doing it right, they were able to get similar grouping. Mind you, it's not going to protect against difference in dropouts, for example. Randomization will not give 100% matching, 100%, but they will be close enough to be appropriately analyzed.
So does randomization eliminate selection bias completely?
In principle, that's the idea. And the larger the sample size, and if it's done appropriately, then yes, it should take care of selection bias.
And I know, doctor, that you mentioned in the beginning of the presentation about the program. So it seems one of the attendees missed it, and he's asking, can you repeat about the availability of softwares for randomization?
So I was saying that you can use anything that you feel comfortable with. Excel, you will see that there is computer generated random allocation softwares that are also available to do so. I'm not very familiar with these ones specifically because I like to use my own softwares, Excel or things like that, because it gives me more control of what I'm doing. There's random generation tables that are out there. There's a number of potential softwares.
Any superiority for one program over the other, or for this computer-based randomization program over Excel, or no?
I'm not. I don't honestly. I have to say I'm not aware of. I'm sure they would be superior, because at the end, if you're creating a software to serve one purpose, then it's going to do much better. Especially, I think if you want to start doing one of the fancy things with adaptive and restricted, if you're not very skilled with using Excel, you might find it challenging, whereas the other softwares might do it for you with simple clicks.
And another interesting question, but I'm not sure if we have the answer. So if there is any artificial intelligence tool for randomization?
That's a nice question. I don't know. We may have to look up for something like this. I didn't, honestly, I haven't thought about it.
So those were the questions for tonight. Thank you so much, Dr. Dimasi, for accepting the invitation and for being an excellent lecturer and teacher throughout these 4 sessions. And we definitely will see you again in future collaborations. Thank you so much. And with Dr. Dimasi enriching presentation, our 4th and last NeuroSTAT webinar comes to its end. Thank you for our esteemed speakers, Dr. Teruzi, Dr. Dimasi, for being with us tonight. Thank you, Novartis, for sponsoring this one-of-a-kind educational activity. And the big thank you goes for you, our attendees, for staying with us until the end of the webinar. I would like to remind you, and actually I received a lot of questions in the Q&A box about that you will receive your certificate of attendance by email within 1 week from today. And this event is actually CME accredited by Mohab for 2 hours of CME. And if you missed any part of this webinar or would like to revisit the lecture, you can check our IVPN NeuroPsychiatry library, where we post all the recordings and all the presentations within 1 week of today. So check our IVPN library, which is currently available free of charge. You can access it by visiting this website and revisit all the lectures. And finally, I would like to remind you to follow us on our social media platform and stay tuned for more educational activity about migraine and other neurological diseases. Our next activity will discuss management of migraine in pregnancy. And I know this is a hot topic in migraine, and many of you would be interested to know how to treat migraine disease in pregnant women. So save the date. This webinar will be on September 25. Keep your eyes on our social media platforms. All the details about the registration will be announced very soon. Until I meet you again, stay safe and have a good night, everybody.